Well, happy World Ovarian Cancer Day, everyone. My name is Cailey Crawford, and I'm the Vice President of Programs and Policy at Ovarian Cancer Canada.
And I am Dr. Alicia, the Scientific Advisor at Ovarian Cancer Canada. We're pleased to be able to give you a sneak peek into how survivors across the country responded to the Canadian edition of the Every Woman study. What we're presenting today is a very brief overview of some of our initial data, but please know that more complex analyses of the data, including diving into regional differences, will be available in the fall.
So the Every Woman Study, Canadian edition, was a comprehensive online survey that was open from September 28th to November 6th, 2020, that aimed to understand the experiences of those with ovarian cancer, particularly in how they accessed and experienced treatment and care. This was a very long survey with over 110 questions, and it took people over about an hour to complete. So I do want to take a moment at this time to just thank each and every one of you who took the time to fill out this survey, because we really do appreciate the time and energy that it took to do that. So this survey explored many topics, and this data will help us to better understand what's working well, what's in need of improvement in terms of diagnostic and treatment pathways, genetic testing, clinical trials access, the provision of psychosocial supports and information, and many other issues that impact the lives of those diagnosed with this disease. Now, I'm going to start by just describing who filled out the survey. So we received 557 responses from women in 10 provinces and 1 territory. And there were 464 English and 93 French respondents. The median age at diagnosis was 54, although ages ranged from 11 to 80 at the time of diagnosis. 61% of respondents had been diagnosed within the last 5 years. We were really pleased with the variety of ovarian cancer types represented. As expected, the most common type was high-grade serous, but we also had many women with low-grade serous, endometrioid, clear cell, and non-epithelial ovarian cancer fill out the survey. The majority of respondents were diagnosed at stage 3 or 4. 41% had either experienced a recurrence or the cancer had never gone away, and 34% were in active treatment at the time of filling out the survey. Now, the self-reported demographic information showed that the majority of respondents were predominantly Caucasian, English or French first language speakers, post-secondary educated, married, and in households with a high family income. So we would have liked to have seen more diversity in terms of these demographics. And it's just important to remember in that context that there are many people's experiences that aren't captured in this survey.
Okay, so regarding family history of cancer, we had a very detailed family history questionnaire, and this was sufficient to build out respondents' cancer histories for 3 generations on both the father's and the mother's side of the family, looking at ovarian, breast, uterine, pancreatic, colorectal, and prostate cancers. But for today, we're just showing you this slide on ovarian and breast cancer. So overall, a third of our participants did not have a family history of either breast or ovarian cancer prior to being diagnosed. 23% had some kind of ovarian cancer history, either with or without breast cancer history. And interestingly, 44% only had breast cancer in their family. So overall, 75% of our respondents had genetic testing or were aware that they had genetic testing. 71%, the bulk of them, were tested after they were diagnosed. 22% were not offered testing, with type of ovarian cancer being the main deciding factor. Women not offered testing were more often diagnosed with non-high-grade serous types of ovarian cancer, which are not as strongly associated with particular inherited mutations. Quite a few of those tested actually had genetic mutations. Again, we are assuming these are inherited, but that's not confirmed. So it's therefore possible that these mutations could just be associated with their tumor and not their bloodline. So 12% of our respondents had a BRCA1 mutation, 7% had a BRCA2 mutation, and 8% had a mutation in one of the other ovarian cancer genes. Most commonly, these were RAD51C, RAD51D, CHEK2, and the Lynch syndrome genes.
We asked those filling out the survey many questions about symptoms, and this is an area of great interest to Ovarian Cancer Canada, as well as to respondents who really stress the importance of raising awareness about symptoms with both healthcare practitioners and the general public throughout the survey. And it should be noted that a patient survey regarding symptoms is typically viewed as biased, as it's retrospective, meaning that respondents are relying on their memory of what symptoms they experienced at the time of their diagnosis. And another limitation is that we don't have a control group of women without ovarian cancer answering questions about whether they're experiencing symptoms commonly associated with ovarian cancer at any given time. But keeping these caveats in mind, we are picking up on some interesting correlations. So without a screening test, as many of you know, getting to an ovarian cancer diagnosis most often relies on women themselves reaching out to a primary care physician when she experiences symptoms. And we listed all the main ovarian cancer symptoms in the survey, and we asked respondents to select all symptoms they experienced prior to the diagnosis. And almost 90% said that they had experienced at least one symptom. And that didn't differ between those who were early stage or late stage. And there could be something interesting happening with age of diagnosis. Women of all ages reported experiencing at least one symptom prior to diagnosis. However, there is a trend towards a slightly increased proportion of younger women experiencing symptoms, specifically among those diagnosed at stage 1. So in this example, we're using on the slide below or above 45 years old to define the groups, but we'll be exploring different age cutoffs. So we'll also be running a more complex analysis to determine whether this correlation depends on the type of ovarian cancer. We're also looking in the process of looking deeper into specific symptoms that women experienced and those that were the most concerning to them. So here we're showing a statistically significant difference in the proportion of women experiencing persistent bloating or menstrual irregularities by stage. So bloating was increased in women diagnosed at stage 3 or 4, while menstrual irregularities were increased in women diagnosed at stage 1 or 2. However, these changes are very small, so they're not likely clinically useful. And we also need to emphasize that the type of ovarian cancer and age at diagnosis likely play a large role. So this will be looked at in great detail over the coming months.
So we also asked a lot of questions about how a woman got to her diagnosis of ovarian cancer. And this is a major area of interest to us. We wanted to collect data that would help reveal the particular hurdles those with ovarian cancer faced in getting to a timely diagnosis. Because if we can identify the challenges people face, we can be specific in our education and advocacy in this area. This work is very complex. There are many factors to consider, but we want to share a bit about the type of data we've collected so you can see the potential we have in trying to get to the bottom of things. So in terms of the pathway to diagnosis, we asked many questions about people's experiences leading up to their diagnosis. What I'm presenting on this slide is a summary of what those who reported having symptoms experienced. Again, this is a summary slide of a lot of data, and over the next several months, we'll be digging into all the data more deeply through more complex statistical analyses. But for now, here is some high-level information. So 500 of our respondents experienced one or more symptoms. Most common were persistent bloating and abdominal pain. So typically within 3 months, 86% of those with symptoms consulted a healthcare professional. 68% went to their family doctor first, and 22% went to the ER or urgent care doctor. Suspected diagnosis at the time by that first healthcare professional was most commonly cancer at 11%, nothing at 11%, an ovarian cyst at 8%, or urinary infection also at 8%. 3/4 of the first healthcare providers ordered one or more tests to investigate the symptoms, either right away, 59% of the time, or after an average of 3 months. The most common tests were an abdominal ultrasound or a transvaginal ultrasound. It's also interesting to note that only 4% of respondents had all 3 recommended tests, including CA-125, transvaginal ultrasound, and pelvic exam, ordered by their first healthcare provider. Close to 90% of our respondents ended up consulting additional healthcare providers beyond that first person. 90% of the time, more tests were ordered, and this time the most common tests were CA-125 blood tests or a CT scan. So from the time of that first appointment to seeing a gyne-oncologist was commonly less than 3 months. And time to diagnosis from that first visit was also within 3 months. But you will see on the next slide that there's a variety of experiences. And speed to diagnosis is not always a good thing. So as you can see in the pie chart, that although the majority of women, 61%, who had symptoms were diagnosed within 3 months of consulting a healthcare provider, the process took longer than this for 38% of women who filled out our survey. So 31% fit within the shortest time to diagnosis category of less than 1 month, and 13% fit into the longest time to diagnosis category, which was greater than 1 year. We are exploring the differences between these 2 groups in great detail in order to understand what impacts the time to diagnosis in both positive and negative ways. So we performed a preliminary analysis of some differences between women in the longest versus shortest time to diagnosis groups. We will continue to look deeper into this over the coming months. So average age of diagnosis is actually lower in those who had the longest time to diagnosis. So to me, this makes sense because if a woman presents with symptoms at this age, the doctor may discount ovarian cancer due to her younger age or think that menstrual irregularities are related to other causes such as perimenopause. We also found that those whose doctors ordered tests right away were more likely to have a shorter time to diagnosis. The identity of that first healthcare provider is also an area that we really want to tease out. We often think about a short time of diagnosis being a good thing, which in many cases it is, but seeing that 0% of those who first consulted an ER doctor were in the longest time to diagnosis category and 24% in the shortest indicates that a short time to diagnosis could be a negative thing in some experiences. For example, we know that women who are experiencing severe symptoms because they're in the late stage often go to the ER to be seen, and they're diagnosed quickly. And anecdotally, we know that sometimes family doctors actually encourage women to go to the ER because they know the time to get an ultrasound with a referral from the family doctor would take much longer than presenting in the ER. So this is an area we are definitely exploring more closely. So the type of ovarian cancer also impacts the time to diagnosis. Women with high-grade serous ovarian cancer were more likely to be diagnosed quickly. In contrast, women with non-high-grade serous epithelial or non-epithelial were more likely to have a longer time to diagnosis, potentially related to the more indolent nature. And by indolent, I mean slow-growing tumors. Women with stage 3 or 4 ovarian cancer were more often diagnosed quickly, and this may be related to those women presenting at the ER due to severe symptoms. So I'm not going to go through this slide in detail, but I wanted to show an example of how we're exploring different variables when it comes to the pathway to diagnosis. So in this example, it's a comparison of those diagnosed with high-grade serous, which is typically diagnosed in stage 3 or 4, compared to endometrioid and clear cell, which are typically diagnosed at stage 1 or 2. This is really just to give you a sense of the many ways we can get more specific. And as another example, we're also looking separately at the data for those who saw an ER doctor as their first healthcare professional versus those whose first healthcare professional was primary care.
We asked a lot of questions, as I mentioned earlier, about symptoms. And one of the questions was, did you know that any of these symptoms were related to ovarian cancer before your diagnosis? And 52%, as you can see, were not aware that any of the symptoms listed were associated with ovarian cancer. We've done some initial analysis correlating awareness of symptoms to a variety of factors. Now, these are preliminary findings, and we do want to analyze these further. But at this point, what we can say is that prior knowledge of ovarian cancer symptoms was not associated with having a family history of ovarian cancer. We also found that prior knowledge of ovarian cancer symptoms was not associated with getting to a healthcare provider more quickly. Now, we want to dig deeper into this. These stats reflect whether those who knew about any of the symptoms went to a doctor faster, not specifically whether those who knew about the particular symptom they themselves experienced went any faster. So we'll be doing some deeper dives into this. An important question we're currently exploring is, could urgency from the patient perspective depend on which type of symptoms they're experiencing? At this point, there's no association between knowledge of symptoms and the overall time to diagnosis. And one thing we'll explore is whether urgency from the physician perspective also depends on the specific symptoms their patient is experiencing. And there's no association between knowledge of symptoms and the stage at which patients were diagnosed with a specific, within a specific category of ovarian cancer. So some really interesting information here that we'll be digging deeper into. And this is showing you a bit more detail on whether prior knowledge of ovarian cancer symptoms impacted how quickly a woman sought help from a healthcare professional. So those who were aware of ovarian cancer symptoms are indicated by the royal blue bars, and those who had no prior knowledge are indicated by the teal bars. And as you can see, there was no difference between these two groups at any time frame. Those who knew about symptoms did not consult a healthcare provider faster. This is a bit counterintuitive, as I think most people would assume that knowing the symptoms will be key in getting to a faster diagnosis, but our initial analysis of the survey results aren't showing this.
Okay, so now we're moving on to treatments. So most of our respondents received chemo, usually multiple courses, which is not surprising. 63% had received their first course within the last 5 years, and also 63% only had to travel less than 30 minutes from home to receive chemotherapy. So we did ask people to select all side effects they experience with chemo, and then to select their top 3 worst side effects. So at the top, you can see fatigue, neuropathy, and hair loss were considered the worst overall. And when we look at responses for those under 40 years of age at diagnosis, we did see some differences, with fatigue, nausea, and joint pain as the worst 3, and with menopausal symptoms coming in higher than in the general group. It's interesting to note that neuropathy didn't show up in the top 6 worst side effects for those diagnosed under 40. Okay, so in terms of surgery, 92% of our respondents had surgery. 63% had their surgery in the last 5 years. 53% did not have to travel more than 30 minutes from home, although it's important to note that 23% had to travel over an hour to have surgery. 87% of participants had both chemo and surgery, and 57% of the time, surgery and chemotherapy were at the same hospital, but the remainder had to go to a different hospital, likely being sent back to the community for chemotherapy. And this is just a breakdown of those who had neoadjuvant chemotherapy, which means they had chemo prior to and following surgery, and adjuvant chemotherapy, meaning they had all of their chemo following surgery. So 45% of our respondents had received at least one other type of treatment beyond chemo and surgery. The most common was a PARP inhibitor. So almost 100 women had received PARP, which are oral drugs that can be taken at home. Not surprisingly, women didn't need to travel far to take treatments that could be taken orally. For other treatments like radiation, anti-angiogenics, such as Avastin, or immune therapy, women typically traveled less than 1 hour from home. Importantly, the distance the patient lived from a cancer center did not seem to impact whether additional treatments were used. Okay, so this is a busy slide, but I just wanted to show an example of how collecting postal code information is allowing us to look at regional variation in the data. You can see here the spread of patients who receive PARP inhibitors across the different provinces. Saskatchewan and the Atlantic provinces had the lowest proportion of respondents who were treated with PARP inhibitors, while Manitoba, BC, and Quebec were at the other end of the spectrum. It should be noted, however, that some of the regions had a small number of respondents.
So we also asked about second opinions, because this is a big question for many diagnosed with ovarian cancer. Patients often wonder whether they're entitled to ask for a second opinion, or they have concerns about asking for a second opinion. So only 31% said they had wanted a second opinion. And unfortunately, less than half of those asked for a second opinion. But of those who asked, almost 100% were able to get one. So we know there's work we have to do in terms of encouraging those who want a second opinion to feel confident in asking for one. Now, in terms of clinical trials, Alicia is going to take it from here.
Okay, so this is another busy slide, but you can see here that of those who responded to our questions regarding clinical trials, 26% said that they were offered a clinical trial and 18% overall participated. So whether a woman is offered or participates in a clinical trial is of course dependent on whether she fits specific eligibility criteria. So a low proportion of women being offered could therefore be due to either a lack of clinical trials in their region, not fitting specific criteria, or a combination of both. So again, we can see that this varied across the country, with Saskatchewan and Atlantic Canada again being on the lower end, and Manitoba and Quebec being on the higher end. There is good news for those in Saskatchewan and Nova Scotia. Although the data in our survey is showing lower rankings, both governments have invested $1 million each to Ovarian Cancer Canada for research and clinical trial infrastructure in their provinces. So when we do this survey again in a few years, we'd expect to see gains in these regions. We also asked about what would drive you to participate in a clinical trial and what would stop you. Not surprising, possibility of a cure and possibility to extend my life would make someone want to join a trial. The top concerns that might prevent someone from participating in a clinical trial are concerns about the safety of the drugs, potential side effects, and worried I'll get a placebo or not adequate treatment. So the fear that one would not get adequate treatment on a trial is a big issue for people, and quite frankly, it's a myth. You might not be on the arm of the trial that gives you the new treatment, but you will always get the treatment you would have gotten if you weren't on the trial, so the standard of care. Also, you're never locked into participating in a trial, but that was also on the list of barriers. So there's work to be done here in terms of dispelling some of the myths around clinical trial participation.
Okay, so moving on to issues related to post-treatment. We asked which long-term effects of treatment people experienced and which did they consider the worst. So overall, people listed fatigue, neuropathy, and anxiety as their top three worst long-term side effects or long-term effects of treatment. And for those diagnosed under 40, their top two were anxiety and fatigue. And of note, we found a statistically significant increase in the proportion of younger women listing anxiety, depression, and menopausal symptoms. We asked about follow-up appointments, and this has been an interesting area of discussion when we've reviewed this initial data with oncologists. Only half the respondents said that they were asked about symptoms at their follow-up appointments, which has surprised many clinicians we've spoken to, as they would have expected that to be 100%. So that's been interesting to discuss with them. And also, as you can see, there is variation in terms of what assessments are conducted at follow-up appointments.
So when looking at information and support needs, we asked, what information did you receive at diagnosis and what would you have liked to receive? So people, not surprisingly, are receiving general information about ovarian cancer, although you would again expect this to be 100%. And it's interesting to see the gap between what was received in terms of information on support and living with ovarian cancer, and how much people would have liked to receive this type of information. So this obviously inspires us at Ovarian Cancer Canada to make sure we can fill this gap, and of course, encourage cancer centers to inform patients about our organization.
In terms of psychosocial issues, again, looking at issues people experienced, and they could click all that apply, as well as the top 3 issues that they found the most challenging. We can see that the fear of cancer coming back and fear of dying and fear that treatment won't work are the top 3 issues that were experienced and that were considered the worst. Fear of the cancer coming back was considered the most challenging regardless of age. But we can see that younger women do have more challenges in terms of loss of fertility, coping with menopause, and sexual intimacy with a partner.
Okay, so we also asked open text box questions to try to make sure we captured some of the nuance behind people's responses. And we're currently analyzing the responses to these 3 questions, such as, would you like to provide any other information regarding your experience leading to your diagnosis? Did we miss anything that would be important for us to advocate about? And is there anything else you would like to share about your experience living with ovarian cancer that was not captured in this survey? So we are busy coding the answers to these, and they'll be really helpful in allowing us to go deeper in our analysis, and will alert us to what we want to ask our statistician to explore more deeply.
So that brings us to the end of our presentation. As we've mentioned, we'll be working throughout this spring and summer with a statistician on further analysis, and we'll be writing up a final report. We'll be sharing our final findings with you at the fall symposium, and we also hope to publish these results and present them to family physicians, gynecologists, and oncologists to make sure that they're hearing you loud and clear. And we'll also be working to develop advocacy priorities informed by the results of this survey. So again, I just want to thank everybody for being here today, and a massive thank you to everyone who took the time to fill out the survey. Your experiences and insights are key to shining a light on the issues that we need to address in our healthcare systems so that those with ovarian cancer can live fuller, better, and longer lives. So thank you once again. Thank you to Alicia as well, who's done so much work on this initiative, and we look forward to updating you again in the fall.
Thank you so much, Alicia and Cailey, for sharing those initial findings. I'm excited to hear more about this at our symposium in the fall.